Duchenne muscular dystrophy, DMD. It is a progressive skeletal and cardiac muscle wasting genetic neuromuscular disease. The dystrophin gene is located on the X chromosome, therefore making DMD an X-linked recessive disease affecting mostly males. The dystrophin gene is 79 exons long. Mostly males are affected because they only have one copy of the X chromosome. Therefore, a mutated gene will lead to disease, as opposed to females who have two copies of the X chromosome in which a good copy can compensate for the mutated copy. Therefore, more males are affected. It is typical that 1 in 3,500 males are affected with DMD. DMD can be inherited genetically or due to spontaneous mutations. The presence of dystrophin in myocytes is critical because dystrophin serves many critical roles. It is a structural protein which provides stability in the sarcolemma. It is an anchoring protein that provides a link between the ECM and the cytoskeleton and has a very critical role in protecting the myocyte from any damage that may occur during muscle contraction. The dystrophin protein complex is located within the sarcolemma, and it consists of sarcoglycans and dystroglycans. It is an important structural unit of the myocyte that interacts with the protein dystrophin. The three important areas of dystrophin include the actin binding end, which binds to the actin cytoskeleton, the central rod, and the dystroglycan binding end that binds to the complex. Thus, dystrophin links the ECM to the cytoskeleton. This linkage is important because it prevents sarcolemma from being damaged when the muscle contracts. Mutations of the dystrophin protein can be caused by friendship mutations, in which the cellular machinery cannot properly read the codons, thus resulting in a non-functional dystrophin protein. Without the functional dystrophin gene, the sarcolemma becomes unstable and susceptible to damage during muscle contraction. In DMD patients, dystrophin protein is often truncated or it is not present. Therefore, without functional dystrophin or without the presence of dystrophin, the membrane is more susceptible to tears and damage during muscle contraction. Therefore, this allows the uncontrolled diffusion of molecules such as calcium to come into the myocyte, in which activates proteases that break down functional proteins and causes necrosis of myocytes. Also, creatine kinase leaks out and into the blood. Levels of creatine kinase can be used as a diagnosis tool. In DMD patients, it is typical for them to experience atrophy of the myocytes, therefore undergo constant regeneration and be susceptible to chronic inflammation, increased fibrosis, an accumulation of fat and scar tissue around the myocytes, which leads to non-contractile muscle. Duchenne muscular dystrophy is a disease that progresses over the lifetime of a patient. Different symptoms are present at different ages. At birth, it is typical for the patient to not display any symptoms, and therefore these patients are diagnosed in their later years in life. During their toddler years, up to 7 years old, they start displaying these symptoms. For example, they have trouble with sitting, walking, talking. They have more trouble meeting the milestones. They experience constant fatigue and falling, which is a sign of muscle weakness. In the transitional phase, which is from 7 to 9 years old, they begin to present more symptoms that are more noticeable, such as the Gower's maneuver, in which the child uses their arms to help themselves stand up. They start walking on their toes, they have an abnormal gait, and they start having heart problems, which need to be closely monitored. In the loss of ambulation phase, which is from 10 to 14 years old, they begin to have more complications. They are more dependent on a wheelchair. They begin to display scoliosis as a result of physiological changes such as a curved spine, and they begin to have heart and breathing problems due to a weakened diaphragm and heart muscle. In the adult phase, which is from 15 years old and up, they began to have increased difficulty breathing and have more serious signs of cardiomyopathy, which often leads to heart failure. DMD patients typically only live up to 30 years old.
Now we know what DMD is, but not much is talked about the transitioning portion that DMD have to go through, from pediatrics to adulthood. Thanks to new innovative treatments, the life expectancy of DMD kids has increased from 26 years old to 30 to 40 years old. This has caused great concern in transitioning for DMD kids. So let's discuss a few points on transitioning for DMD kids. The first point is about factors that contribute to transitioning. Second point is currently what is being done to address transitioning. And the third point is going to be about suggestions or recommendations for the development of a resource database that physicians may use after diagnosis for DMD patients. So let's discuss a little bit more about what point number 1 is. So the factors that contribute to transitioning. One of them is proper guidance by the physician. Another one is patient autonomy. So what is meant by proper guidance? Basically is the physician giving the DMD patient the proper resources that they need to be able to navigate their life. Then for patient autonomy, what is meant by that is that giving the DMD patient their own voice when they're in their clinical visits, instead of the patient's parents having to say yes or no to certain treatments or yes or no to other questions that the physician has for the patient. Now, going on to point number 2, what is currently being done for transitioning for DMD patients? Through the literature, it's been seen that there's very limited resources that physicians have to be able to give to the DMD patients, which is kind of distressing for certain families, but at the same time, physicians do have to see other families and have to help them. So that is why sometimes when such a rare disease comes up in a clinical healthcare, it is hard for a physician to be able to really give those resources out. And another thing that's been seen is that physicians usually talk with the parents rather than the DMD patient, which makes it a little bit harder for the DMD patient to gain autonomy for later in adulthood. So we're going to go on to point number 3 and give our suggestion for the resource database that the physician may be able to use to help increase the likelihood of a successful transition for DMD patients.
Care for DMD patients extends into adulthood. Since it is a fast progressing disease, it is very important that the transition from pediatric treatment into adult treatment is well planned and introduced to the family in order to mitigate any challenges. One key improvement for transition planning is to practice and assess independence of the patient in order to provide effective support. It's recommended to begin this type of planning around the age of 13 or 14, but this discussion should start earlier on because it helps patients set goals and understand how they can still contribute to society despite their disease. Healthcare providers are a great starting point for this conversation and should encourage this type of planning and incorporate it into each visit. Other key components of a successful transition are the care coordinators, healthcare, education, employment, housing, transportation, finances, and relationships. The care coordinators are there to lead discussions and hit every topic. It is important that DMD patients continue with their pediatric care until they are fully transitioned into their adult healthcare provider. It is also important that parental support is still present and for healthcare providers to outline long-term plans with their prognosis. It is reported that a low percentage of DMD patients have established adulthood plans, and many even stop treatment after pediatric cares because they are faced with challenges that they had not planned for. These challenges can be transportation or how to deal with insurance. There is a lack of resource to support and educate patients into their transition into adulthood. Therefore, it would be helpful to possibly give rise to a database where multiple resources could be easily accessed by not only the healthcare providers, but patients and families as well. This would allow for an early on exposure to give time to the process and discussion of the transition into adulthood and to establish independence. One resource that already exists is Got Transition, which is a website where families and care providers can go to research many different topics as previously discussed, like insurance, transportation, and finding different clinics. They even have an outline of steps to help you throughout your whole process and planning.